Welcome to Johns Hopkins Medicine online webinar series. Today, Johns Hopkins cardiologists Cedars and Stacy Fisher will be speaking about living with adult congenital heart disease. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenters. The last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching the presentation, so please note if you do not want your name attached to your question, please check send anonymously. We will do our best to answer all questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. Please note this program is being recorded. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Cedars and Dr. Fisher to begin our presentation.
Well, thank you very much for that introduction, and it's a pleasure to be here tonight to speak with you all. As you heard, we're going to be talking about living with congenital heart disease today. I'm super happy to be here with my new partner, Stacy Fisher, we hope to have a good presentation to give you some new information and to be available to answer some questions afterwards. So to get started, I think, the most logical thing to begin with is a definition of congenital heart disease, because although many of you may have congenital heart disease or may have been told what congenital heart disease is, or perhaps you're even a provider and are familiar with congenital heart disease, the reality is that it still remains a fairly rare condition. And so I think starting with a definition is helpful in understanding the rest of the presentation. And so what congenital heart disease is it's a type of defect that affects one or more of the structures in the heart or blood vessels that occurs before birth, which is to say, individuals who have congenital heart disease are born with it. And it turns out that congenital heart disease is the most common form of birth defect, affecting approximately 40,000 live births annually in the United States. So this is not an unusual condition. And up until probably the 1950s, the great majority of people with the more complex forms of heart malformations or congenital heart disease would die in childhood. And so there was really no need to have a field of adults with congenital heart disease because the majority of patients would perish in childhood, unfortunately. But as a result of better surgical understanding, the great proportion of these patients now live until adulthood. Now, we're not just talking about one singular disease process. Congenital heart disease represents a broad array of different diagnoses. Almost any imaginable malformation of the heart, the valves in the heart, the great vessels that carry blood to and away from the heart can be abnormal or connected abnormally in a way that leads to congenital heart disease and that requires repair in childhood. And so there's a lot of creativity involved in the repair of the majority of congenital heart disease lesions. Now, interestingly, the birth of cardiac surgery, when you think of like coronary artery bypass surgery or valve surgery, was actually with congenital heart disease. And it started here at Johns Hopkins with these people. To the far left and going from left to right, you see Helen Taussig, who was a pediatric cardiologist caring for individuals born with congenital heart disease. In the middle, you see Alfred Blaylock, who was the surgeon who performed the first blue baby surgery, which was the first surgery to palliate, not correct, but palliate people born with tetralogy of Fallot, which is a form of congenital heart disease. And to the far right is Dr. Blaylock's lab tech, who's Vivian Thomas, who actually was the pioneer behind the procedure that earned the fame of being called the Blaylock-Taussig-Thomas palliative procedure, or shunt, for tetralogy of Fallot. And before these individuals did this surgery, and before this surgery was performed at Johns Hopkins, there really wasn't much in the way of cardiac surgery. And a large part of the reason for that is that The heart is a moving object. It was thought that in order to be able to get in, do a repair, and get out without the patient bleeding to death was not possible. Now, since these early days of surgery, the advent of cardiopulmonary bypass, whereby the heart is stopped and the heart can be emptied of blood so that it can be operated upon and any number of different repairs can be performed, has allowed for the vast array of different congenital heart diseases to become treatable. So just as examples, these are kind of 4 diagrams depicting some of the ways in which congenital heart disease can be repaired. In the far left, you see a heart that looks actually reasonably normal. And this is the type of heart that may have a hole between the top chambers of the hearts called an atrial septal defect, one between the bottom chambers of the heart called the ventricular septal defect, or one between the aorta and the pulmonary artery called patent ductus arteriosus. These hearts are actually repaired in a quite straightforward manner now that we have cardiopulmonary bypass and end up looking fairly normal after childhood. However, that represents only a small proportion of people who have congenital heart disease. Many people have much more complex forms of congenital heart disease. The next diagram to the right is a patient who is born with tetralogy of Fallot, the very same lesion that led to that early surgery developed by Blaylock Thomas and Blaylock, Tausig and Vivian Thomas. And with that surgery, you see that the heart is left with a patch between where the right ventricle is and where the pulmonary artery is. And this has certain very well recognized long-term side effects for adults who have a repair of this type in childhood. The next heart is one in which the ventricles are not in the right positions. The right ventricle is pumping blood to the aorta and the left is pumping blood to the lungs, which is the opposite of what should be the case. And in older days, the type of repair that was performed is depicted here, which is called either a mustard or a Semming repair. By this repair, the venous return to the heart is rerouted across the heart to the left ventricle, and the pulmonary venous return to the heart is rerouted across the heart to the right ventricle, effectively switching around what was switched wrong at birth. And this allows people to do very, very well long into adulthood. Finally, you see a heart which was born from an individual who was born with only one functional ventricle. And in this situation, the venous return to the heart has to go directly to the lungs, bypassing the heart, because there is no right ventricle that normally pumps blood to the lungs available to pump blood to the lungs. And so there's a vast array of different types of surgeries, different congenital lesions, and different long-term side effects that can result from these different surgeries. And so every one of our congenital heart disease patients is a unique individual and requires specialized and individualized care that's dependent not only on the lesion with which they were born, but on the specific kind of repair that they had when they were a child, and then on the ways in which that repair may have over time slowly begun to deteriorate, or the ways in which the initial repair or the underlying disease with which somebody was born may interact with just good old-fashioned acquired heart disease, because nothing about being born with congenital heart disease somehow magically protects you against the development of coronary artery disease, atrial fibrillation, all of these other types of of heart disease which are associated with normal aging. And so ACHD is important because it's a rare abnormality that's becoming more common. Because of advances in surgical and medical care in childhood, more and more patients are living and thriving into adulthood, and these patients have chronic heart disease that requires monitoring. The majority of our patients are younger and therefore have this kind of youthful bulletproofness. And because we're dealing with patients who are younger, who have youthful vivacity, patients may be sicker than they think they are or than they look like they are, and require very careful long-term monitoring. And because, as you'll see, specialized care by adult congenital heart disease providers makes a difference in clinical outcomes. So whereas congenital heart disease used to have a face like this, the face of congenital heart disease now is more like this. Proof of this comes from Canada, where they're able to monitor their population for diseases much better than we're able to in the United States, where we don't have kind of nationalized healthcare. And you can see that at least since the year 2000, the numbers of individuals over the age of 18 with congenital heart disease, depicted here in red, has exceeded the numbers of individuals younger than 18 years of age with congenital heart disease, here depicted in purple. And this goes for all congenital heart disease in the upper graph, as well as those with the most complex forms of congenital heart disease, those which would have been lethal in childhood were it not for surgical repairs. And these patients are not just living to adulthood, they are thriving and living long in adulthood. And this is data from England, where you can see that in one of the largest adult congenital programs in the world, at the Royal Brompton in London, England, you can see that the numbers of individuals over the age of 60 followed in that clinic has been progressively rising since the year 2000. And again, you see this is not only those with the most simple forms of congenital heart disease, which in the right-handed graph are depicted by the blue line, but numbers are increasing as well for those with more complex forms of congenital heart disease, suggesting that although born with a lethal cardiac abnormality, people can live and thrive into adulthood. But I tell my patients that their hearts are more like Ferraris than they are like Hondas. My heart's like a Honda. It's not super exotic, and it doesn't require very frequent repairs. Whereas congenital heart disease patients have an exotic heart that's going to need to be in the shop periodically, but it doesn't mean it can't run wonderfully well. Now, as an example of the ways in which the Ferrari may from time to time break down if not adequately monitored, you can see that in the population, again, in Canada, those with congenital heart disease have a twofold risk of being hospitalized compared to the general population if you compare the middle bar with that furthest on the right. And those with the most complex forms of congenital heart disease are hospitalized 3 times or more frequently than the general population, as you can see in the bar furthest to the left. And as a result of repeated hospitalizations, as well as deterioration of prior repairs, at this point in history, patients with congenital heart disease die younger than the general population. This is data from the Netherlands, and you can see compared to the general population in the Netherlands, depicted by the black hashed line, the age of death among those with congenital heart disease is earlier. If you look at those with the most simple forms of congenital heart disease, indicated in green, their longevity fairly closely resembles those in the general population, but those with either intermediate or complex forms of congenital heart disease, here depicted in blue and red respectively, life expectancy is not as great. And as a result of this, there are guidelines that we follow as adult congenital heart disease experts regarding monitoring and treating patients with congenital heart disease. Now, unfortunately, because of congenital heart disease being quite rare, and because there are just, as I have mentioned, a broad array of different lesions, a broad array of different surgeries done in childhood, it's been very, very challenging to come up with therapies, because the large drug trials that we have done and which have been so beneficial in the adult population, the acquired heart disease population, it's hard to do those big trials in congenital heart disease because already congenital heart disease taken as a whole is rare. And with each specific anatomy and each specific repair being completely physiologically distinct from the others, you can never get a very large population of patients together. And so that very heterogeneity that makes our patients so special is actually an impediment to our ability to define good therapeutic strategies. The population is small, as I have said, and because the population is small, industry isn't super interested in investing in large trials or in the development of devices or drugs which are of benefit to the adult congenital heart disease population. And then finally, because adult congenital heart disease patients generally do pretty well, we can't look and track to see if there's a change in mortality or a change in hospitalization rate that results from any type of intervention, be it a new drug or a new device. And so what are we left to do? How is it that adult congenital heart disease providers can help patients? And the way that we help patients is we know what types of things can happen to you. We know the predictable ways in which surgical repairs in childhood may deteriorate with time. And we know the ways in which acquired heart disease is going to interact with your congenital heart disease and are able to prevent problems from occurring. And it has a clinical benefit. Here again is data from Canada. And what you can see in there are two different bars, and I'll walk you through this, or two different lines, and I'll walk you through this. You in the gray line, the light gray line on the bottom is depicting the number of adults with congenital heart disease in the general population in Canada, and the number who are their rate of death. And so you can see that in the bottom gray bar, that the rate of death among individuals with congenital heart disease started to drop off around 2000. And what happened around that time was that guidelines came out in Canada just about 3 or 4 years prior, where it was recommended that individuals with congenital heart disease begin to be followed at a specialized care center. So the top line indicates the number of patients followed by an ACHD specialized provider in Canada. And you can see that around the year 1996-97, the number of adults who were with congenital heart disease who were seen at specialized centers increases. And that actually, after a couple of years, resulted in a decrease in mortality rate. Now, lest you think that this is just some statistical happenstance that occurred as a result of the passage of time, when you look at the rate of mortality or the survival probability among individuals followed at a specialized care center, here indicated in the solid line, compared to those followed at a non-specialized center, here indicated in the dashed line, the survival is superior with specialized care. And for that reason, it's super important that people with congenital heart disease receive subspecialty care, receive care from an adult congenital specialized provider. A part of the service we provide is helping you live the most full life that you can. And that includes getting married, that includes having children, that includes participating in sports, that includes living life and participating in the type of occupation that you want with your life. And so now I'm going to turn it over to my colleague, Stacy Fisher, who's going to tell you about some of the ways that we're able to provide essential counseling for life events to allow you to live the longest and best quality life possible. Stacy, I think you're on mute. Stacy, you're still muted. There you go.
Hi, everybody, and thank you, Dr. Cedars. It's such a pleasure to be here. And as Dr. Cedars said, what we want is to normalize as much as possible the anatomy and also the life expectancy. So our goals are really trying to get you the best quality and longest life that we can. And that is getting better and better as technology is getting better. So we want to try to allow everybody to do the sports that they want to do, but we also want to make sure that they're safe. So if we look at the types of sports that people choose to do, they can be divided into skill, power, mixed sports, and endurance sports. And that type of sports and the type of athleticism needed to do these sports really affects blood pressure, heart rate, cardiac output very differently, and it can affect the way that the heart structure and function is over time. So we look at the types of sports people like to do and also what's good for people based on their anatomy and their availability. And there is a lot of testing that we can do, such as metabolic stress testing or exercise testing, where we can try to make sure that somebody's safe in a type of sport. Sometimes what we do as far as preoperative assessment is similar to what we do as far as athletic assessment, where we're trying to make sure that both your anatomy, your energy, and your ability and reserve are safe for the types of sports that you want to do. So if we go to the next slide, part of the evaluation for athletic participation and takes into account the athlete's wishes, and that periodically needs to be reevaluated. We look at their balance, we look at their performance, and we look at their hemodynamics. And what I mean by that is the blood pressure and EKG and heart rate response to exercise. So we look at parameters at rest, including oxygen levels, EKGs, rhythm issues, anatomy. And then we do stress testing to actually look at what happens to their blood pressure, their oxygen levels, and their EKG. And we look for rhythm issues. We look for higher risk signs that somebody may or may not have difficulty with different types of exercise. And then we look at the requirements in your body for what happens if you do the power exercises or the skill exercises, and make recommendations based on what is safe and what is reasonable, and try to help people do the things that make them happy and safe, but not necessarily things that can have long-term negative effects. So that is a personalized evaluation in somebody that has structural heart disease that really is very important to do if you have had issues in the past, or if you're not sure. If we go to the next slide. A similar issue with what is your cardiac reserve, and can you actually tolerate a change in the reserve or increased work that the heart has to do, would be pregnancy. So there are now more forward-thinking registries of pregnancy. A lot of our pregnancy data comes from 2 large observational studies, and now there's some forward-thinking studies where we're getting better and better data. And we try to risk stratify people when they're interested in pregnancy. Things that are very high risk would be any history of heart failure, breathlessness with activity, lower heart pumping function, anticoagulation use, any valves that may or may not be functioning well. So artificial heart valves, whether the mechanical or tissue valves, these things should be discussed before pregnancy. So we strongly, strongly encourage people to actually have what we call preconceptual thought or counseling, so that you can actually look at what is your risk. Is there risk to you beyond what it is for other people? What is it? Can you do anything to optimize your health before a pregnancy, so that you could actually have a healthier, better pregnancy and better chance of a good outcome for your child? Or is the risk really prohibitive where it's dangerous for you and your child to actually have a pregnancy, where maybe other types of family planning would be more appropriate? So this is something to personally have with your doctor, and we strongly encourage you, if you're thinking about taking chances with pregnancy, to actually look. The next slide. Another thing that we need to think about is, what is the risk to the future child? So in congenital heart disease in general, there's about a 1 to 10% risk of congenital disease in the child. In certain conditions like Marfan syndrome, for example, if somebody has that gene, it's a 50% risk in the child. And in other types of congenital heart disease, it's more like 5 or 10%. There now can be early screenings, including fetal echocardiography, where we actually look at the child's heart, and our colleagues in fetal medicine do studies as early as 12 to 15 weeks, where they can actually see if the child has a normally developed heart or if there are issues. So this is hugely progressive and very accurate in actually figuring out if you can, for example, deliver in a community center, if you need to deliver in a center that has childhood care. So for example, if you know that your child has a heart issue, you may want to deliver in the center where the child's heart doctor can practice and where there's cardiac surgery available for the child. So you'll know actually what is, what the condition is, what the issues are. You can have a chance to meet with the childhood heart team and make decisions about the best care for you and your child based on accurate data. In patients with congenital heart disease, the overall fetal mortality is about 4%. Most of the issues are in the higher risk patients. So for example, people that have a single ventricle that's been palliated, people that have low oxygen levels or mixed circulations, and people that have high blood pressure in the lungs. So that's one of the biggest risks, pulmonary hypertension. Very important because most of our patients actually do incredibly well through pregnancy and delivery, but we do want to improve the care. Our team is a team where we actually use all aspects of the team. So for example, in somebody who has high blood pressure in the lungs, we work also with lung doctors. In somebody who has a high risk of a genetic condition, we include our genetics counselors and geneticists. And in somebody that needs an intervention, we use our interventional colleagues or surgeons. So we really do function as a team. And we want you to have a very strong village in taking care of you so that you can have the most normal, healthy, long life that you can. And that's what the centers do. And that's why people do better in the centers of care.
And so to conclude, I think a lot of patients who are born with congenital heart disease, after they grow up and they go out into the world and they leave their parents' home, they don't have somebody standing over them saying, you need to go see your cardiologist, otherwise you're going to get into trouble. And as a result, many people are lost to follow-up after the childhood area and get lost in the city. Here, this is Baltimore, but you can get lost in any city, really. If we can reinforce no other point here, it's that seeing a specialist in adult congenital heart disease, if you happen to have adult congenital heart disease, has a real tangible impact on your longevity and the probability of you having complications later in life. We really can help you enjoy the life that you want to enjoy. But it is important that you have medical follow-up, if not with us, then with another adult congenital provider, to make certain that you're receiving appropriate screening and care for your specific condition. And with that, we'll conclude and we're open for questions.
So the first question that I see is, how often do you recommend congenital heart patients receive regular checkups? So there's not a perfect answer to that. It depends what you've actually had. And many of our patients had childhood heart surgery and then don't even know what they had. So they're not really sure, do they need care or not? So what we'd recommend is an initial evaluation where we really try to get your past records. We figure out what you've had. If we're not sure, we do imaging and or stress testing, like the metabolic stress test, so that we can give you real and accurate information about what's safe, what's not safe. There may be somebody who had a hole in the heart fixed when they were 2 or 3 years old, has essentially no sequelae of that, and can come maybe every 5 to 10 years, where we may have somebody who actually has heart failure with congenital heart disease that needs a lot of changes or intervention or medication adjustments and may need to come every few weeks or every few months. Most of our patients come about every 6 to 12 months, depending on what the underlying issue is.
Looks like the next question is it common for any CHD to go undiagnosed at birth? Absolutely, 100%. There are some CHDs which are clinically silent until much later in life, unless somebody is really looking for the problem. Most likely, I would say the great majority of defects are quite apparent at birth, if for no greater reason than because they'll create some turbulent flow in the heart, which the pediatrician will be able to hear with his stethoscope. However, there are certain lesions. The one that pops to mind immediately is congenitally corrected transposition of the great vessels, which may be clinically silent at birth and go completely undiagnosed. Stacy, can you think of other ones?
Yeah, so a lot of times the ones we find in adult are the ones that don't make a lot of noise. So things like a hole in the heart between the top 2 chambers. The bottom 2 chambers of ventricular septal defect is loud and noisy and it's picked up early, but the top chamber can be pretty quiet. Another one that's very common is anomalous pulmonary veins. So there can be veins that instead of draining to the left side of the heart, drain to the right side of the heart, and then the heart gets very big. So that has to recirculate the blood. And those are silent. So people will present often very late with either a rhythm issue or swelling or shortness of breath. But those are mainly the symptoms that somebody might have if they have something that's showing up late.
The next question is medication ever preferred over surgical treatment? The great majority of congenital heart disease is due to defective anatomy or abnormal anatomy. And so you can't really correct an anatomical abnormality with medicine. Now, that's not to say medicine has no role in the therapeutic armamentarium to treat congenital heart disease. And we use lots of different medicines to help improve outcomes with congenital heart disease. But to truly correct congenital heart disease does require some kind of interventional procedure where you are altering the anatomy in some way. Now, that doesn't necessarily mean a scar on the chest. It can be a procedure that can be performed in the cardiac catheterization laboratory, where through a small hole in the artery or the vein in your leg. But almost all congenital heart disease to be definitively treated it requires some way you are modifying the structures of the heart.
Right, so trying to normalize or near normalize the anatomy. And if we can't, then we just want a circuit that works and that takes the most pressure available off of the pump. So we want the muscle protected every way it can. I love the next question, so I'm going to start that one. Is there any technology such as an app that helps patients living with adult congenital heart disease? So there is great technology and it's making a huge difference. The smart watches are hugely helpful in trying to understand things like arrhythmias and palpitations, or checking for heart rate ranges. And that can be very helpful because many of our patients do have heart rhythm issues. It's actually a high number in the 50s or 60%. Of patients that over their lifetime with congenital heart disease may have heart rhythm issues. So we deal a lot with our electrical colleagues, with medications, with exercise programs, and these applications and apps are helping us to find them with less time and less monitoring. So there are also mobile apps that you can get that will actually take a 6 or 12 lead EKG. And we can actually use those EKGs in the care and in diagnosis and treatment of people to try to help figure out what's going on. I don't know if you have experience or like other apps. The diet apps are also good, like Noom or Weight Watchers.
Yeah, I mean, I love the Apple Watch. I tell many of my patients to get an Apple Watch if they're having symptoms that are sufficiently infrequent to not be easily picked up on routine monitoring. But I also, we actually here at Hopkins have a healthcare app that was specifically designed for adults with congenital heart disease that facilitates communication of symptom burden as well as vital signs in between visits with the provider. And it allows us to kind of be there with you at all times so that when you have symptoms, you can kind of indicate it on your phone and send a message to us, letting us know how things are going. And that's something that we're in the process of rolling out in our clinics. The next question is, can you explain the impact of the traditional recommendation for aspirin post-surgery on heart patients? Well, that's a challenging question. I assume that you're probably speaking about post-surgery in people who have coronary artery bypass grafting or who have surgery for coronary artery disease. And in that setting, I think aspirin can be of benefit in preventing heart attacks in the future. In the adult congenital heart disease population, we use aspirin a little bit differently. Typically, we use it after a new valve has been put in to kind of protect the valve from blood clots forming on it. There can be some other situations, though, in which we use aspirin post-surgery. So, Stacy, what other situations do we use aspirin post-surgery?
Sometimes we use aspirin if we're worried about clotting. If there are any issues with the veins or clotting, sometimes if there is a small residual hole, we'll use aspirin to prevent stroke. generally, some of our patients, because again, we treat adults, some of our patients also have coronary or vascular disease or carotid disease or lipid abnormalities. So we will use aspirin in that setting as well. So around heart surgery, if we're recommending aspirin after the surgery, there's usually a reason where it either is decreasing inflammation or clotting. But it's not a routine for everybody. The next question is, do you ever completely advise against exercise in your patients? So the answer is only if they're unstable, awaiting something to fix them. But the goal of trying to help our patients do well is to try to help people pick things that are safe and good for them. But we want people to be active. It really helps the muscle, the arteries, everything to have activity. So if somebody has a situation where they're unsafe for any type of exercise, then they generally have a situation where they really need some sort of intervention or change, because that would not be a stable situation. So exercise truly does help the hemodynamics, the blood pressure, your whole well-being, your demeanor, decreases depression. It's very important as a person that you can actually have that. And we want you to be active. It maintains your ability to be independent. So if somebody truly can't exercise, it's because we are waiting to get something done or in the process of trying to get them safe. So it's a dynamic where we continue to discuss what are the reasons, what can they do, what can't they do. We may need a few days, for example, after a procedure to let wounds heal, where we don't want people to exercise or to hurt the healing of a wound. But we don't have a situation where we have long-term no exercise restrictions. Exercise restrictions are recommended in people that may have an aneurysm that's under surveillance, where we don't like heavy lifting or the real straining type procedures. For people that have obstruction to blood flow, we may not want them doing real heavy exercise or things where they're straining. We like people to be able to speak a short sentence during exercise, to do the aerobic parts and kind of a low to moderate level in those scenarios.
Yeah, I agree with Stacy completely. I mean, I think in general, exercise is good. And I really would like almost all of my patients doing some form of exercise, but an exercise prescription, like Stacy's talking about, individualized recommendations for exercise are super important in congenital heart disease.
Yeah, and if we're not sure, there are cardiac rehab programs, right?
I beg your pardon?
If we're not sure about the level of exercise, we also have partners in cardiac rehab, which is a formal monitored exercise program that is generally insurance covered if someone has had valve surgery or has heart failure or has coronary disease.
That's absolutely right. So the next question we have is, are there support groups or other resources available for your patients living with congenital heart disease? Well, just to speak first very broadly, there is a national patient advocacy organization called the Adult Congenital Heart Association, which can be really beneficial for patients. They have all sorts of connections with local support groups, as well as information on local adult congenital specialized clinics, providers, names and telephone numbers. It's a huge resource, and they have a website that's easily accessible on the internet. But there are also local resources and local support groups, right, Stacy?
Absolutely, and we have a Hopkins adult congenital support group, which is really something that I absolutely love being part of. Where we generally meet quarterly. We have had some downtime in COVID and with other transitions, but basically we meet 4 times a year, and we have an educational component and a social component so that people can meet other people that have congenital heart disease and have similar struggles. And we found this to be extremely helpful in understanding and just kind of coming up with workflows for your own life that are very helpful, and just, the questions of what's normal, what's not normal, or what might make it easier from somebody who's been through something like a an open heart surgery for somebody that is about to have one. So it's extremely helpful, and you're welcome to email us if you'd like to add your email to our support group list. We are going to have another Zoom meeting on December 20th at 7 p.m. And you're certainly welcome to join. So we want patients with congenital heart disease. Often they'll bring a spouse or a family member or a child so that they can have support. But we are primarily there for the adult patients.
Is there a clear difference or benefit in using a bovine or pig aortic valve replacement? Well, that's a kind of a loaded question. I actually don't know how many pig valves there are still that are implanted. I think the majority of currently implanted valves are bovine tissue, although I could be wrong about that. But you know, the decision about the type of valve to use for aortic valve replacement is really pretty individualized, and will depend on the particular patient and their particular disease process. So I think it's hard for me to say which one is beneficial. You know, in terms of, I think most valves are bovine now, but there are also mechanical valves. There are also transcutaneously placed valves, and which one is right for any individual person is going to really depend on what's going on with them. And so this is an important kind of multidisciplinary, individualized decision-making process.
Right, and I would say, you know, even more so, it's really important if you need a heart valve that the whole anatomy is taken into account. So you're going to also talk to your cardiologist, but also your surgeon in the selection of that valve, because we're really looking at the size and the shape and the long-term performance of the valve. We're also looking for long-term care of the valve. So for example, if you're getting a tissue valve rather than a mechanical valve, it probably won't last forever, depending how old you are and what your underlying health is. And you may need another valve, which sometimes can go in through a catheter to replace the one that's there. So a mechanical valve requires the blood thinners, but should outlast any human being because they're carbon. So there's a lot of nuances that go into valve selection. There's lower profile mechanical valves. Sometimes people don't just need a valve, they actually need a root or a part of the artery replaced for the pulmonary or the aorta, and that will change the type of valve that you're picking. So we can't just say, oh, we love the porcine valves versus the bovine valves. It's more, what do you need? Why do you need it? What is the size, shape, and anatomy around it? And what else it can affect? And how will that affect you in 10 years? So that's the conversation that you want to bring back to your care team.
How long is recovery after surgery? Well, that's again, that's not something that we can give you a single answer to. It's going to be variable depending on exactly what type of surgery you're having done, and upon how healthy you are when you go into surgery, how old you are when you go into surgery. Obviously, people who are less healthy, less active, and older will tend to have a more difficulty recovering from surgery than somebody who's otherwise healthy, young, and active. Somebody who's having a multiple valves replaced or multiple different procedures performed all at the same time is going to probably have a longer recovery than somebody who's having only a simple single valve replaced, or maybe doesn't even need to go on the cardiopulmonary bypass machine. So that's going to really be variable depending on exactly the surgery that's done.
So the next question is it common to have multiple surgeries over the course of a lifetime when diagnosed with congenital heart disease? And the answer, unfortunately, is yes, but also in a positive way is yes. So in people that have more severe structural issues, a lot of times the initial surgeries are done when they're very young, so maybe 6 weeks of age at this point. And people are growing at that age, and sometimes you can't get parts in that will be big enough for a full-size adult. So that's one of the common reasons where some of these things that are done at the beginning are meant to get people to survive the initial stages, to grow, to be healthy, and then to actually have more permanent procedures later. And just like we started to talk about the valves earlier, some of the valves are tissue valves where the body will break them down over time. And over time, you actually do need to go ahead and replace the ones that are breaking down. So we try to do the least interventions. We try to actually stage the interventions at times. So if you have, for example, a simple hole between the top two chambers that's fixed either surgically or with a device, you probably won't need anything else done. But if you have something like tetralogy of Fallot, it's as many as 90% of the patients that will need to go on to have a pulmonary valve later in their lifetime. And then that pulmonary valve at this point in time is a tissue valve, will last anywhere, say 8 to 20 years, and then they are going to need something else done. So there are definitely times where we have staged and planned sequential procedures or surgeries over the lifetime with the goal of normalizing the anatomy and normalizing the life expectancy.
And then finally, can you do anything to prevent congenital heart disease from developing in your baby when you are pregnant? And to that question, I would answer that unfortunately, at least at this point, there is nothing that we know of that will prevent congenital heart disease in a developing infant. However, that doesn't mean that it's not, there aren't things we can do to optimize the probability that if you have a child with congenital heart disease, that child has a good outcome shortly after birth. And that includes seeing your obstetrician regularly, making sure that you get anatomy ultrasounds. If the child has abnormal anatomy, that abnormal anatomy in the unborn child can be monitored in utero for early surgery and early care after birth. Stacy, what else do you have to add to that one?
So just a little bit more. First of all, the healthy habits, avoiding drugs that can actually cause defects in the child. So for example, drugs like ACE inhibitors, if people are on medications for their heart, talking to their doctor ahead of time and changing to safer drugs in pregnancy can prevent other types of birth defects. They won't affect the genetic part of congenital heart disease. So far, we have a lot of genetic screening for things like aortic disease, but not as many for things like congenital heart disease. There are some syndromes, however, that we do have screening for. And if you know that you have a gene causing congenital heart disease, there is the possibility of egg or embryo screening for the same gene, where you could donate your own eggs, have the gene screened in the eggs that you've donated, and have fertility to replace the eggs that don't have the gene. So for example, if you have Marfan syndrome, which is a fibrillin gene mutation, if you have that abnormal gene and you're a woman, you could have the eggs screened, your eggs screened, and they could screen out the genes that the eggs that actually have the fibrillin gene change and just leave you with the eggs that don't have those genes. For a man, it's a little bit harder, but they can do embryo screening. So there are fertility options where you could meet with genetic counselors and fertility specialists to discuss trying to screen out those genes. So that is something that's emerging and just becoming more available, and it's something that we like to counsel if somebody has one of the syndromes that we can actually identify genetically.
Well, thank you everybody for joining tonight. It's been great spending a little bit of time with you. And please don't hesitate to reach out to us at the contact numbers here indicated if you would like an appointment or if you would like to speak with us further about congenital heart disease care.